Good afternoon, everybody. My name's Victor Kalf. I'm one of the moderators with Professor Ignazi here.
So now the next speaker is Professor Sharmila Darbala. She comes from the Brigham and Women's Hospital in Boston. She's a world expert on cardiac PET. And she will discuss for us coronary flow reserve and perfusion imaging.
Thank you, Dr. Karyu. Good afternoon, everyone. I would like to start off by thanking the meeting organizers for inviting me. Melbourne is beautiful. This is my first trip here, and I'm really enjoying the meeting a lot. So what I would like to do over the next 20 minutes is talk to you a little bit about PET perfusion imaging and coronary flow reserve. So why PET? So in order to understand this, I think we should review a little bit about temporal trends in coronary artery disease, data from the United States showing that in the earlier part of last century, deaths from coronary artery disease peaked, and then now you start seeing a decline. And this has translated into perfusion imaging as well. Data from the Cedars-Sinai group showing that when you look at SPECT myocardial perfusion imaging, the number of people who had no ischemia or abnormal SPECT has declined consistently all the way from the early 90s to 2009. So what's happening here? Why is there a difference? Why are we seeing less SPECT? And we think it's because of better medical therapy, revascularization, and much better management of ischemic heart disease. In addition, there's surgical data where they looked at plaque from carotid arteries from endarterectomy specimens, and these investigators have shown that the plaque itself has changed. You can see on the top, you have more macrophages, you have intraplaque hemorrhage, higher lipid core and calcification. This is what we were seeing earlier on in the 2000 to 2003. And now if you see at the current period, 2010-2011, you see that those macrophages have gone down, lipid core has reduced, calcification has decreased, hemorrhage has decreased. Why? And we all believe that this may be because of statins and how statins are changing the plaques, and of course, better risk factor modification and control by patients. So all of these leads you to believe that our conventional techniques of ischemia detection sufficient in this era when you're seeing that SPECT imaging is detecting less ischemia, plaques are changing, mortality is going down, and all of this says that we need better techniques to detect coronary atherosclerosis at an earlier stage, at a non-obstructive stage, and probably even better techniques to detect microvascular disease. And I think imaging advances for evaluation of ischemic heart disease and patients with ischemic heart disease need to keep up with the changing natural history of coronary atherosclerosis because of all the factors we discussed earlier. So what are the advantages of PET? PET is quantitative. It can provide accurate attenuation correction. The traces are well defined. They can assess microvascular dysfunction, higher signal to noise ratio, high sensitivity. Targeted imaging is possible with some of the specific tracers, and it provides rapid tomographic imaging, and I'll discuss this a little bit. This rapid tomographic imaging is a feature that's very important in order to quantify myocardial blood flow. And then hybrid imaging gives us the option of not only looking at perfusion, but also looking at the CT component and identifying calcified atherosclerosis. Here's an example of a PET protocol. If you perform a rest and stress, most PET scanners currently are hybrid PET CT scanners. So you obtain a scout image to localize the heart, and then you position the PET scanner over the heart, take a CT scan for attenuation correction. Then you inject the radiotracer and take an emission image. The two most commonly used radiotracers for perfusion with PET are rubidium-82 and N13 ammonia. O15 water is used in Europe, but it's not FDA approved, whereas rubidium and ammonia are FDA approved in the United States. So if you use rubidium, it's a 7-minute scan. With ammonia, it's a 20-minute scan. So as soon as you complete the rest, you perform a stress test, which takes 1 to 15 minutes, followed by the same sequence. So if the patient is on the table and not moved between the rest and stress, you can eliminate this scout image. You can straight away go ahead and get the radio tracers, and you do not need the second CT image. The big advantage of PET compared to SPECT is dynamic imaging. So what is dynamic imaging? So dynamic imaging is one where you start the scan and then inject the radio tracer and acquire the images. So you start your scan, inject the radio tracer, and you can see that if you put region of interest in the right ventricle, left ventricle in the myocardium, you can develop time activity curves. So this is time or counts here, and this is time or frames. You can see the activity peaking in the right ventricular cavity, in the left ventricular cavity, and finally you see activity in the myocardium. So using this dynamic acquisition in regions of interest, you can perform kinetic analysis using 1 to 3 compartment models, and then you correct the images for radioactive extraction and decay as well as for partial volume related corrections. Then you can compute myocardial blood flow in ml per gram tissue per minute. So you know how much tracer you've injected, you know the time it takes, you know the input function. So if you correct for this, based on the uptake in the myocardium, you get myocardial blood flow. So typically this is done at rest and at stress, which is vasodilator for the most part. You can also do it with dobutamine. And the ratio of the myocardial blood flow at stress divided by rest is what is known as coronary flow reserve. So if you perform a standard N13 ammonia PET, you get excellent quality perfusion images. Here you can see on top stress and rest. The interpretation is standard. You look at the polar plots, you look at the gated images. One difference on the gated file with PET compared to SPECT is your wall motion assessment occurs during maximal hyperemia. So you give the vasodilator and you start your scan with the injection of radiotracer. So this gives you the opportunity to measure ejection fraction at rest and during maximal hyperemia. This is particularly important with dobutamine, where you may see the augmentation and EF response with dobutamine. So this patient obviously has extensive ischemia in the left circumflex as well as in the right coronary artery. The ejection fraction is also low, and multi-vessel coronary disease was confirmed on angiography. So our lab as well as other labs have looked at changes in EF from rest to stress, particularly with rubidium-82, and have shown that in patients who have extensive or severe coronary disease, the ejection fraction does not increase with vasodilator stress. In fact, the ejection fraction may decrease, and it is a high-risk marker. What about the diagnostic accuracy to detect obstructive coronary disease as seen on angiography? There's 2 meta-analyses here, and both of them show that SPECT, here you can see sensitivity and specificity in the area under the curve. You can see that PET has much better accuracy compared to SPECT. And here's another meta-analysis where they looked at SPECT with attenuation correction. Again, showed that the area under the curve is superior for PET perfusion imaging compared to SPECT perfusion imaging. So both of these studies, using a reference standard of obstructive epicardial disease, show that PET is superior. What about if you use fractional flow reserve, a measure of ischemia, during coronary angiography, where you use Doppler flow wire to measure velocity across atherosclerosis using fractional flow reserve? This is a meta-analysis, and these investigators have shown that the area under the curve for SPECT is 0.82, 0.83 for echo. You can look at MR 0.94 and PET 0.93. So clearly MRI, PET, and as well as CT seem to have better accuracy at detecting hemodynamically obstructive coronary atherosclerosis using fractional flow reserve as a measure. What about the prognostic value of PET? I think several investigators have looked at the prognostic value of PET. I'm just sharing with you one of the studies from 4 different institutions. And this study showed very nicely that long-term follow-up in patients who have a normal PET scan, they have very low event rate. Patients with severely abnormal scan have a much higher hazard of cardiac death. And these curves are very similar to what all of you are familiar with SPECT myocardial perfusion imaging, again suggesting that PET is not only helpful in terms of diagnosis, but also helpful for risk assessment. So when you look at head-to-head comparison of CT coronary angiography, SPECT, and PET to detect myocardial perfusion ischemia by FFR. So this was a prospective study where they looked at patients with stable angina who underwent all 4 tests. 208 patients, new onset stable angina. Everyone underwent SPECT CT perfusion imaging, followed by CT coronary angiography, O15 labeled water PET CT, and invasive coronary angiography with FFR. And in this study, you can see that PET, PET CTA, SPECT, SPECT CTA, and coronary CTA. You can see sensitivity is highest for coronary CTA. When you look at specificity, you'll notice that specificity is higher for PET, PET CTA as well as SPECT CTA, but not as much for CT-based evaluation. So overall accuracy for PET, PET CTA is in the 85% range. For SPECT, with SPECT CTA is in the 76-77% range, and with CT angiography 74. So this is the first study to look at the same patient undergoing all the different tests to show that overall accuracy for PET, PET CTA seems to be better than SPECT or CT coronary angiography. The biggest question that we all hope that PET can answer is, if the scan is completely normal, does this patient have balanced flow reduction, or is this completely normal? So this is a major problem that we all face with, particularly with vasodilator stress, where you don't have ECG or hemodynamic data. And we are all hoping that PET with quantitative flow assessment could help in this regard. So a little introduction into the coronary circulation. As you're all familiar with, the coronary arteries are these major big arteries running on the surface, and this big array of microvessels that go and supply blood flow to the myocardium. Epicardial circulation is nicely imaged by either invasive or CT-based coronary angiography. Both of those techniques do not have the resolution to image these minute vessels. Perfusion imaging and perfusion defects on SPECT or PET identify epicardial coronary stenosis plus minus microvascular disease. Fractional flow reserve, which is a lesion-based metric, also identifies epicardial coronary disease. On the other hand, if you look at coronary flow reserve with quantitation, then it's a good measure of epicardial as well as coronary microvascular circulation. Here's a schematic again showing discrete or diffuse epicardial disease, and here's the microvasculature that's more responsive to metabolic processes. FFR is a lesion-based metric where you put a Doppler flow wire across the lesion and check the pressures distal to and proximal to, whereas coronary flow reserve gives us an assessment of flow variation not only related to epicardial stenosis, but also related to metabolic regulation of the microvasculature. So that is something important to keep in mind, that FFR and CFR are not looking at the same thing. FFR is a lesion-based metric, so if you have a lesion in the LED circuit in RCA, you need to run 3 different FFR measures. And coronary flow reserve is a global metric, epicardial microvascular. You can do a regional CFR for each of the territories, but again, remember, it's not just giving you assessment of epicardial, but it gives you an integrated assessment of both epicardial and microvascular dysfunction. So coronary flow reserve is a ratio of stress divided by rest, myocardial blood flow. It's unitless. Normal values vary by the protocol, radio tracer, somewhere between 3 to 5 in completely healthy adults. FFR is an invasive angiographic metric, vessel or lesion based. It's using Doppler flow wires, and again, it's defined as mean pressure distal to a stenosis, divided by mean pressure proximal to a stenosis. Mean aortic pressure. All right, so that is what is the definition of FFR. So there have been clinical trials looking at FFR-guided PCI compared to angiography-guided PCI, just looking at obstruction, showing that survival free from major cardiac events is much better with FFR-guided PCI compared to angiography alone. So investigators have looked at the relationship between CFR and FFR. So here's a graph showing CFR and FFR. And the two metrics indicate different parts of the coronary circulation. So if your CFR is reduced, let's say below 2, right, and your FFR is also reduced, so both are reduced and concordant, then that tells you that the patient likely has obstructive coronary disease as well as microvascular dysfunction. On the other hand, if your CFR is reduced but your FFR is normal, where there's discordance, then it says it's more likely to be diffuse than focal or only small vessel or microvascular dysfunction. Of course, if both are normal, this side, everything is normal. On the other hand, here, where your coronary flow reserve is normal, but your fractional flow reserve is decreased, less than 0.8, that could be because of focal branch vessel disease in one of the branches, and it usually indicates that it's more likely to be focal disease than diffuse disease. So preserved coronary flow reserve, more importantly than reduced flow reserve, preserved CFR is more helpful in patient management. And data from multiple laboratories have shown that as the myocardial flow reserve decreases, the likelihood or probability of three-vessel coronary disease increases. But you'll notice that even at a myocardial flow reserve of 1, only 40% of the patients or less have multi-vessel disease, and the rest of them are so-called microvascular dysfunction. So therefore, this metric is not very helpful per se when it is decreased, but when it is preserved, it effectively excludes significant multivessel disease with a 97% negative predictive value. So global hyperemic myocardial blood flow of more than 2 ml and a flow reserve of more than 2 reliably exclude the presence of high-risk angiographic CAD with a negative predictive value of over 95%. So what is the data supporting this? Cardiac mortality, when you look at cardiac mortality in relation to perfusion defects shown on this axis, or coronary flow reserve, upper tertile in blue, middle tertile in orange, and lower tertile in green, you'll notice immediately that patients with the lowest tertile of coronary flow reserve have the highest event rates. And you also notice that as the perfusion defect size increases, the event rate increases. So both perfusion defect and flow reserve together are very helpful in determining cardiovascular events. Low CFR indicates a high risk of major adverse events, even in patients with zero coronary artery calcium. So this is data from our lab by Dr. Masanao Naya, showing that in patients with even a calcium score of 0, if your coronary flow reserve is less than 2, then the annualized major adverse cardiac event rate is much higher compared to those patients where the CFR is normal. Similarly, Viviani Taketi from our lab has looked at reduced coronary flow reserve and revascularization options. So focus on this side here, CFR low, no revascularization, PCI cabbage. You'll notice that in patients where the CFR is low, cabbage seems to have a much lower annualized event rate compared to no revascularization. And here his PCI compared to cabbage, also much lower revascularization. So these are the first data to suggest that in patients with low coronary flow reserve, complete revascularization with coronary artery bypass surgery may have the potential to improve outcomes. So if you look at integration of coronary flow reserve and myocardial blood flow, so why should we integrate the two? If you think of it, coronary flow reserve is a ratio, stress divided by rest. You can have a situation where stress flow is very reduced, but rest flow is even more reduced, and your ratio looks apparently normal. So the question is, does that matter? So that is what we looked at in this. Dr. Gupta from our lab looked at this. Here's maximal myocardial blood flow, coronary flow reserve. Of course, if both are reduced, then those patients are at high risk of events. But if your CFR is reduced, even with a maximal myocardial blood flow that's high, your CV mortality rate is high. Okay? And of course, this is normal. And here's a situation where your maximal myocardial blood flow is reduced and your coronary flow reserve is normal. So this is where your rest is also reduced. So if stress is reduced, rest is reduced. It could be because the patient's on a beta blocker or something like that. And those patients have an intermediate event rate compared to normal patients. So again, these are the ways where you can use all this literature together. So I want to just share with you some of the guidelines that are published on this topic. So there's one guideline from SNMMI and ASNIC looking at SPECT-CT, PET-CT imaging. Then there are several guidelines. Sorry, this is telling me I'm done. There's several guidelines from ASNIC on SNMMI looking at PET, looking at also myocardial blood flow. So I think all of these are excellent resources. They're available for free access on the ASNIC website for those of you that are interested. So to conclude, when should PET be considered for optimal patient care? PET is a preferred first line in patients with known or suspected CAD in whom exercise testing is not feasible. It's recommended in patients with suspected active CAD who meet the criteria for breast imaging and also meet one or more of the other criteria. So what are those? Prior image with poor quality, body characteristics suggesting attenuation, high-risk patients, young patients, and patients in whom myocardial blood flow quantitation may be necessary for clinical management. When should absolute myocardial blood flow be considered? Patients who present with symptoms suggestive of myocardial ischemia and microvascular dysfunction, where you have known coronary disease by angiography and more specific evaluation is required. Increased suspicion of multivessel disease, you look at regional coronary flow reserve, assess microvascular dysfunction, and to evaluate for heart transplant vasculopathy. So the last slide is when should myocardial flow reserve be reported in clinical practice? Typically, if your perfusion is normal and CFR is high, you report that because that is a very low risk feature. Patient probably does not require any further evaluation. If you have abnormal perfusion with a relatively worse CFR, you would report that. If the clinical question is microvascular dysfunction, you report that. And if the clinical question is hemodynamic significance of obstructive lesion, then you would report that as well. So thank you very much for your attention.